Implementing the Dyad leadership model is our episode topic. My guest is Tammy Powers, a registered nurse and chief executive officer at Sutter Roseville Medical Center. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Tammy, thank you so much for joining us today.
Thank you, Nick, for having me. It's great to see you again and be part of this.
Before we get into our episode topic, can you share a little bit about yourself with our listeners?
I'm the Chief Executive Officer at Sutter Roseville Medical Center, part of an integrated health system in Northern California, part of Sutter Health. Sutter Roseville is a 419-bed acute care hospital, level 2 trauma center, providing specialty services across a very large network of care that really stems from the northern Sacramento area all the way to the Nevada state line. Really, I'm just really proud to get to be here today, Nick, and thank you for allowing me to join you.
Thank you. Our topic today is implementing the Dyad leadership model. What does an effective Dyad relationship look like in healthcare, and why is it so critical for organizational success?
I think that, Nick, people talk about the Dyad relationship a lot more than I realized before I started getting to learn about the Dyad relationship. But when we talk about the Dyad relationship at Sutter Health, we're really talking about a partnership with administration and our physician leaders. And one of the new models that we've really been centered around the last 2 years is developing an integrated model with our chief medical executives and our chief executive officers at each of our acute care hospitals, as well as across our service lines. And when I talk about a successful Dyad relationship, it really is a true partnership, being very clear in what our roles are, what focuses each of us has, and then also how do we partner together to lead the strategic and the operational priorities for our organization, really cascaded from our overall system focuses from both our chief executive officer at the system level to our chief physician officer and our chief operating officer at the system level.
So that's the vision, and that's what your actionable items are. But how do you build that trust and maintain transparency between the physician and administrative leaders in this Dyad model?
For us, it was a real change from how we'd done that in the past here at Sutter Roseville. And I think the way it starts is by building a very strong relationship at the frontline level. So my Dyad partner, Dr. Walker, and I really started at the very same time. Our roles started at the same time. So we had a unique opportunity to build this relationship from the very beginning versus managing through a change where some of our other leaders might have had a different experience than we did. But for us, it really stemmed from what is important to each of us in the roles that we have. What is the work that we each feel we need to focus on in our own organization? So really stepping back together and looking at how are we performing? Where is our opportunity? Which one of us is going to take the lead on some of the work that we've identified as a priority? Being clear with our teams on which of us is leading that work, but also the structures we have together on how we touch base with each other, how we check in with each other. All of that started with a one-on-one together and saying what's important to each of us and how do we want to partner together? How do we want to work together? Learning each other's strengths, our opportunities, putting a lot of energy and focus into making sure we're leveraging that together so that our teams at the end of the day, it isn't who's this, who's that. It's how are we working together as a team? That was a change for us at the Roseville community. And it's really been embraced because people know that together we are carrying the same message forward. We may spend a lot of time dialoguing together behind closed doors, but at the end of the day, when we walk out that door together, we're a team. And that helps our physicians understand that we're working together. It helps the physicians know that there's a physician at the front working with me, not me bringing the physicians in after a conversation, but together. She's really representing that voice of the physicians. It's really changed the dynamic of administrative and physician relationships on this campus.
Excellent. And so, what strategies have you found most effective for resolving conflicts or differences? You talked earlier about you may have your conversations in private, but then when you walk out, it's one face, one message.
Yeah.
What other strategies have you found within the dyad that have worked really well?
I think open, transparent conversation and really ensuring that we embrace focused feedback. Dr. Walker and I, in particular, we meet every day. In fact, we actually carpool quite a bit. So we get to do a lot of dialoguing, right? So that's not something that everybody can do. But we have formal time where we talk about our strategies, our performance. But at the end of the day, doing a focused feedback, how did that meeting go for you? What insights do you have? How could that have gone different? Do you feel it could have gone different? I'd welcome your insights to that. Has been a habit that we've had to build on over the last 2 years. We have learned together that there's certain areas where each of us have a different strength. And so just because, for example, there might be a physician-focused conversation that we need to have based on my background or my strength, we have a conversation before the meeting. Maybe this will be one, Tammy, where you take the lead in this conversation, or, hey, this one's going to be a little bit more challenging for me. I have a lot of passion around this topic. How do we want to approach that so that we are coming together in front of the groups that we're meeting with? So being comfortable and taking time to have that strategic conversation before we go into some of these bigger meetings together has been something that we have had to refine and practice and be really intentional about. But at the end of the day, we all as leaders have to find ways to get feedback from one another. And the one person I look to the most is my dyad partner to say, hey, how could that meeting have gone different? There was a lot of angst during that discussion. Was there something that we could have pivoted and done differently to maybe reduce that angst? Or could we have been more clear in that conversation? I depend on her to give me that focused feedback. And she depends on that for me, which is helping us be a lot more strategic with our teams because we're really refining and changing the way we're working with our teams almost every single day.
You mentioned earlier about taking the time. So I'm just curious, how does the dyad model impact decision-making speed and quality compared to the traditional leadership structures that are out there that are not using a dyad model?
Yeah. So I think that a lot of people assumed that the dyad model and decision-making would slow down because I think a lot of people's belief was, all right, if Dr. Walker as my dyad partner is going to lead a physician discussion, then she'll have to come and talk to me about that. And then we have to make a decision. So it's just one more layer. It actually hasn't been that. For us, we approach strategic decisions together. And what we've implemented here with our team so that they're very clear on how we are needing a decision or a recommendation to be made before we even start a conversation. So we're working towards an initiative around, I'll use length of stay, for example, which is very driven very much from a physician and a nursing perspective. When we started an initiative around our length of stay initiative at Sutter Roseville, we actually implemented the DARE model, which is really decision. Who's going to be the deciding factor? Who's going to make the decision? Who's our advisors? Who's our recommenders? And then who are the people we're going to depend on to execute that initiative? So every time we're having a strategic discussion or a strategic focus, or we're setting a goal or a metric, we go through that process ahead of time so that we can be very clear so that we are not confusing the team on who that decision maker is going to be. When it is a situation where both of us need to be that deciding factor, then we're very clear about that. And then we approach that, listening that recommendation together, and then we drive that decision together. But being intentional about whose role is what with the rest of the team is helping us not limit how fast a decision gets made. I think right now we're not immune to the fact that we're having to move at a pace that's probably faster than we've ever had to move from an organizational healthcare perspective. Things are changing almost every day. So how we pivot, how we move, how we learn from moving quickly is really critically important. So we're focused on creating that atmosphere where we want to be clear on what we need the team to work on, who needs to make that, drive that decision, how we want that recommendation come in, what's the timeline we need that in, so that we're not delaying making decisions so that we can keep moving at the pace we need to.
In ballpark, what percentage of the time are you working on consensus versus having a clear person that's in that decider role?
I don't know if I have an exact percentage, Nick, but I would say when we're looking at our strategic initiatives that we are focused on this campus in particular, I would say that majority of those, there's a decision maker that needs to happen. A
Okay.
majority. I don't know if I can give you an exact
But
percentage,
more than half.
but at least more than half. I think that when we're doing stakeholder analyses or we're trying to really understand the tone of the group or feedback from the group, that's where we're seeing more consensus discussion. But when we're using this model of really defining roles and who's going to make that decision, those are we're using that most of our time for our strategic initiatives.
As I'm listening to you talk about this role, and I'm familiar with other organizations that use the Dyad model, but you've got some unique relationship strengths here where you're carpooling together and you've got that opportunity to talk about things. And as you were talking, a term came to my mind, and this may be completely inappropriate, but it's the work spouse. Is that a fair assumption that you're a team and you're leveraging each other's strengths and you're a partnership together? Is that fair?
I guess so. Yes, in some ways, if you want to look at it that way. I think that what I've seen from a culture perspective is, and I can only speak from my own personal experience, there has always been an administrative structure within healthcare, right?
Sure.
There,
Yeah.
and then there's the nursing structure within, and nursing is a majority of the workforce that we utilize in a hospital setting, right? Physicians are an critically important voice to how we care for patients as well. And I think what we found, at least within our health system, is that we did not have the voice of the physician as integrated as we could have. And we really needed to identify an infrastructure where we truly had the voice of our physicians helping guide how we care for patients in the communities that we're serving. And this was a critical change where we said at every decision and every strategic discussion that we're having, or any what we call strategic operational focus that we're discussing within the hospital environment, we're going to have an administrator and a physician help lead that work. We always depend on our nursing teams to be part of that, because I think in some settings, our nursing leaders, we joke, Dr. Walker and I, we're a dyad partner, but we also have a triad and we also have our operations leaders. The CNE is critically important in this model as well. So it can't be distinct and different. But yes, I would say that in this scenario, my work partner is really my chief medical executive on this campus. And we are leading the strategic vision of this campus. And then we are pulling our other strategic partners like our chief nurse executive, our chief operating officer, our chief financial officer, or our other leaders across the campus in to help us lead that work depending on the role that they have.
Now, you are the chief executive and your Dyad partner is the chief medical, is it chief medical executive or chief medical officer?
Chief medical executive.
Okay, chief medical executive. Is there also a chief medical officer then that aligns with the chief? I'm just trying to understand
Yeah.
who your chief nurse is, because you're a nurse that's also the CEO, but who is your chief nurse's partner and how does that work organizationally?
Great questions. We do not have a chief medical officer. We have a chief of staff who is responsible for the governance of our medical credential providers on the campus. And they have a very distinct and different role than the chief medical executive, right? They are responsible for ensuring that all of the physicians caring for patients on this campus have the credentials to do so. But our chief medical executive, who is my Dyad partner, also pivots and supports our chief nurse exec on clinical initiatives that happen on this campus. Our chief medical executive primary responsibility is obviously helping to support the strategic initiatives of the campus, whether for this campus or in the process of elevating to a level 1 trauma center. Her role is critically important in helping us do that work and really making sure we have the complement of physician specialties that we need to have on this campus, but also the link in with our residency program, for example, and or our community partners to help support the level 1 trauma requirements that we have in the state of California. That being said, she also pivots and is responsible for the clinical quality performance of this campus. And she partners with the chief nurse exec for that work and our chief quality officer. So she does have a dual role in regards to that. We partner for that work. But at the end of the day, I have to ensure that we are fiscally responsible, that our operations, we're meeting all of our regulatory requirements to ensure that we can maintain our licensure as an acute care hospital. And also, I really am responsible for ensuring that we're programmatically able to support the operations of this hospital. So that's where maybe there's a little difference. But again, I have to also lean into my chief nurse exec, my quality officer, my chief operating officer, my chief financial officer to help me support some of those critical work efforts that I'm responsible for.
Excellent. Thank you for clarifying that. What advice would you give to organizations or leaders who are just starting to implement this dyad structure?
The most important thing is taking time to get to know each other's strengths and really having some transparent conversations about your things that are really important to you, how you guys, what structures do you need to keep communication open? But it isn't a one and done. I think it's really critically important that as a dyad relationship that you continue to come back and have conversations on a regular cadence. Dr. Walker and I on a quarterly basis sit down and we look at these were the goals that we set for each other as a team. How are we doing on those goals? How are we communicating? Do we need to look at something different? What are the things that we are seeing as critically important for us to address as we move into the next 30 days, 90 days, 120 days? Because how we are seeing things in the view or the lens of our role might look different. And so we need to make sure that we've really are on the same page on what we need to prioritize and focus on, because that ultimately cascades down to the team that's working with us.
And then recognizing that you're chief executive and have a dyad and you have other dyads that exist within your organization, how as chief executive are you promoting the dyad model at the individual service lines and other places that you see dyads structured?
We have partners in our medical group. We have partners in our foundation, which is the infrastructure that supports the clinics, the ambulatory clinics. So just within what we consider our subdivision, our teams in the medical group and the foundation also have dyads. So our foundation partners, so the individuals that are leading the ambulatory clinics have a dyad physician partner that actually works with them to ensure that the ambulatory infrastructure, so that handoff from the hospital to the foundation and medical group is very strong. So who are those individual partners that we work with? Because ultimately they're helping to support the programmatic work that we do on the campus as well. Our physicians obviously are helping with acute care coverage models. For example, we might have hospital-based programs that those physicians also are integrated in. So having that network across the foundation and the medical group and then at the hospital, those dyad teams have to partner with each other each and every day. Dr. Walker and I actually have a dyad structure that we report into. We have a division chief medical executive officer and our president of the Greater Sacramento division. We actually report up to them. So we have dyad partners that we report into, and each of our acute care hospitals have dyad partners that we partner with. And in a great example, one of our smaller facilities about 20 miles up the road, Dr. Walker and I partner with that CME and that CEO to really talk about how we manage capacity across both campuses. So that dyad relationship has been really important so that we're working in partnership with the physicians and the leaders that are in both our entity and their entity as well.
Any closing thoughts as we wrap up this episode?
The importance of communication and being open to trying things new. This was a new structure for us 2 years ago. It's not perfect, but having the opportunity to continue to think about how we leverage a relationship and building trust, which again, reiterates out to the teams that are working with you, the power of partnership and collaboration.
Implementing the dyad leadership model has been our episode topic. Tammy Powers, thank you so much for your time today.
Thank you, Nick. I appreciate the time.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.